Welcome back, fifth-year students. Ready to crush your pharmacology exams? In this explainer, we're diving into a real game changer, monoclonal antibodies for respiratory diseases. We're going to distill Professor Matera's lecture down to the absolute high-yield mechanisms, the clinical phenotypes, and the real-world applications you absolutely need to know. Here's the roadmap for today. We'll breeze through the immunopathology and precision medicine basics, break down the specific monoclonal antibodies for asthma, see exactly where they fit into treatment algorithms, tackle the tricky world of COPD management, review the pharmacokinetics, and then wrap the whole shebang up with a rapid-fire exam review.
So check out this ancient insight from Hippocrates. It is more important to know what sort of person has a disease than to know what sort of disease a person has. Honestly, this perfectly captures why we just don't hand out the same inhaler to every single patient anymore. It lays the groundwork for targeted therapy because, as you know, not all patients respond to standard treatments, and some even get hit with toxic adverse reactions.
Section 1, Immunopathology and Precision Medicine. Let's jump right in and see how this builds our foundation for figuring out exactly which patient gets which drug. Okay, so what exactly is precision medicine? Well, it's all about matching specific biomarkers to clinical phenotypes. Now, in respiratory pharmacology, our weapons of choice are monoclonal antibodies. These are massive, 150 kilodalton heterodimeric molecules derived from IgG immunoglobulins. By pinning down the right biomarkers, we massively increase our chances of giving the right patient the right drug at literally the perfect time.
Now, underline this in your notes. Biologic therapies primarily target the Th2 high phenotype. Why? Well, because eosinophils are the main culprits here, releasing toxic proteins that wreak havoc in asthma pathogenesis. We're talking about major basic proteins that straight up inactivate M2 muscarinic receptors, plus eosinophil cationic proteins and peroxidases that kick off major oxidative stress. The biologics we're about to look at, they target the specific biomarkers driving all this toxic eosinophilic inflammation. Moving into Section 2, monoclonal antibodies for asthma. With that pathology fresh in our minds, let's get into the specific drugs and the mechanisms of action you'll see on test day.
First up in our arsenal is omalizumab. This drug specifically targets free IgE antibodies produced by B lymphocytes. By grabbing onto that free IgE, omalizumab takes it out of circulation, which in turn drops the expression of Fc epsilon Ri receptors on mast cells. No receptors means no mast cell activation, and that stops the release of those inflammatory mediators that rile up the eosinophils. Bottom line, it stops excessive mucus production and structural airway remodeling dead in its tracks. Okay, pay close attention here because examiners love this highly testable difference between our two IL-5 inhibitors. Mepolizumab targets the free cytokine itself right in the lungs, but benralizumab, it takes a totally different route. It binds directly to the alpha subunit of the IL-5 receptor, completely preventing it from dimerizing. And here is the high-yield kicker. Benralizumab also actively induces antibody-mediated cell cytotoxicity, or ADCC for short. That means it actively destroys circulating eosinophils. Keep in mind, though, both of these drugs work to inhibit eosinophil hematopoiesis down in the bone marrow. Next on the list is dupilumab, which is actually the first fully humanized monoclonal antibody for bronchial asthma. And it's a real overachiever. It hits two cytokines with one stone. By binding the IL-4 receptor alpha subunit, it prevents dimerization with the IL-13 receptor. So boom, you've effectively blocked both the IL-4 and IL-13 pathways, which, as you recall, drive IgE production and goblet cell hyperplasia. Finally, we've got tezepelumab. This one works way upstream. It prevents the activation of IL-7 receptors, which antagonizes TSLP, an alarmin that the epithelium releases when it's stressed out by allergens or oxidation. Section 3, Biologics in Treatment Algorithms. Knowing the drugs is great, but the crucial point here is knowing exactly when to actually prescribe them. If you look at the GINA, ERS/ATS, and EAICI guidelines, there is a totally clear consensus you absolutely do not use biologics as first-line monotherapy. No way. You only add these bad boys on top of standard triple therapy. You know, your LABA, LAMA, and inhaled corticosteroids. And only for uncontrolled patients who meet specific biomarker thresholds. We're talking high eosinophil counts, elevated fractional exhaled nitric oxide, or FeNO, and a history of severe exacerbations over the past year. Section 4, Biologics and COPD Management. Let's pivot for a second to a major clinical curveball that examiners absolutely love to throw at you. Think about this for a second. We just went over an incredible arsenal of asthma drugs, right? But why did biologics like omalizumab and benralizumab show literally zero significant efficacy in COPD trials? The answer comes down to immunopathology. COPD generally just doesn't have an eosinophilic phenotype. It's a completely different inflammatory pathway. And actually, when researchers tried targeting IL-8 to stop neutrophil recruitment in COPD, they had to halt those trials. Why? Because unfortunately, targeting IL-8 was linked to an increased risk of cancer. But there is one major exception you need to memorize, and that's dupilumab. It's approved for a very specific COPD subgroup, specifically patients with high eosinophils and high FeNO. Uniquely, dupilumab increases IL-23 and IL-17. This activates T17 cells, which is awesome because it actually protects these COPD patients against the bacterial and fungal infections that usually trigger their exacerbations. Oh, and keep an eye on emerging targets too, like itepekimab and tozoricimab. They target IL-33, a cytokine dumped by damaged epithelial cells in COPD. Section 5, Pharmacokinetics and Monitoring Needs. We've got to cover this because the sheer size of these molecules dictates how we monitor them clinically. You absolutely need to know this recycling mechanism step by step. Remember, monoclonal antibodies are massive. When they're circulating, they bind to bramble receptors, also known as FCN receptors, and get endocytosed right into a lysosome. Now, normally, lysosomes destroy things, right? But here, the low pH actually stabilizes the bond between the antibody and the receptor. This brilliant little trick rescues the antibody from degradation, recycling the whole complex back to the plasma membrane where it's released safely back into circulation. It's this exact mechanism that gives these drugs their incredibly long half-life. Red flag this number right here, too. Because of that massively long half-life we just talked about, almost all of these monoclonal antibodies are dosed just once a month. But there's a highly testable exception. Dupilumab uniquely requires subcutaneous dosing twice a month. Put a big star next to that one. As for clearance, keep in mind these molecules are way too big to be filtered by the kidneys. Instead, they undergo target-mediated drug disposition, which is saturable, and nonspecific clearance via proteases. And here's the best part. Because proteases basically just chop them up into simple, reusable amino acids, there is literally zero metabolic toxicity. That means your clinical monitoring totally shifts. You aren't constantly checking for liver or kidney damage. Instead, you're monitoring the drug's structural traits, like increased liver clearance if it has galactoglycosylation, the patient's age, and making sure there aren't any interactions with other immunosuppressants. Section 6, High-Yield Exam Review. Okay, let's bring this all together. Here are the exact rapid-fire facts you're going to want to review the night before your boards. First, omalizumab targets free IgE to block mast cell activation in T2 high allergic asthma. Second, mepolizumab directly binds free IL-5 in the lungs to halt eosinophil activation. Third, benralizumab blocks the IL-5 receptor alpha subunit and uniquely induces antibody-mediated cell cytotoxicity, actively depleting those eosinophils. Fourth, both of those IL-5 inhibitors stop eosinophil hematopoiesis right at the source in the bone marrow. And fifth, dupilumab blocks the IL-4 receptor alpha subunit, effectively shutting down both the IL-4 and IL-13 signaling pathways. Continuing that thought, that dual blockade is exactly why dupilumab treats both severe Th2 high asthma and that specific high eosinophil COPD subgroup we talked about, requiring twice-monthly sub-Q dosing. Next, tezepelumab works upstream, antagonizing IL-7 receptors to block the epithelial alarmin TSLP. Clinically, remember that these biologics are strictly add-on therapies. They're only for uncontrolled cases already maxed out on standard triple therapy. Pharmacokinetically, Bramble's receptors rescue mAbs from lysosomal degradation to extend their half-life. And finally, their clearance via proteases into safe amino acids ensures zero metabolic toxicity. I'm going to leave you with one final thought to ponder for your exams. If these drugs are incredibly targeted, effectively bypass renal clearance, and break down perfectly safely into amino acids with zero metabolic toxicity, what's really stopping us from combining them all right now for a total cure? Well, while clinical trials are actively testing multi-target combinations as we speak, the astronomical cost of these highly specific therapies remains a massive barrier. Good luck studying, you're going to do absolutely great, and we'll see you in the next explainer.